My name is Tracy Martinez, and I have the pleasure of introducing your next speaker of this session. This is a small group. You might think about moving closer, but if you're comfortable where you are, that's fine. Chris Still is a good friend of mine and a mentor, so it's a pleasure to introduce him to you today. He's been studying the field of obesity and nutritional support for over 2 decades. He didn't want me to say that, but it's important to know his wealth of knowledge. He directs the Geisinger Center for Nutrition and Weight Management, which is in Pennsylvania, as well as the Obesity Research Institute. I think part of the reason he's so passionate and successful in what he does is he has a personal story of battling weight himself. At one time, he weighed 385 pounds. He lost weight and had a career change experience. And today, he's board certified in internal medicine. He's also certified in nutrition, the American College of Nutrition, among others. He is a lifelong member, being one of the founding board members of the Obesity Action Coalition. He is, I was going to say he taught me everything I know, but maybe I taught him everything he knows.
That's right.
He's a wealth of knowledge. Chris?
Thanks, Trace. Thank you. Well, thank you. It's a pleasure to be here today. What I would like to do today is just talk about a little bit about the pathophysiology of obesity, and then hopefully that will give us a better understanding in the new treatment options. It's really been an exciting field. When I went into this field, as Tracy said, about 20 years ago, everyone thought I was so silly or stupid. What is obesity medicine? And no one can believe that I did that. But as Tracy said, it was really a personal choice and a real interest of mine. I was in veterinary medicine at Penn State, and I lost the weight and then switched over and got my master's from Columbia, then went on to medical school, and then did a fellowship in obesity medicine and nutrition support. So it's really been a great experience for me and very worthwhile livelihood over the last 20 years to see the transition of obesity medicine in the care for the chronic disease of obesity. So the good news is there's good in the future with regards to therapeutics, both in pharmacotherapy and I believe in endoluminal endoscopic procedures and also in the surgical procedures. I think there's a lot in the horizon for the disease of obesity. And the other thing, as you all know, is that the AMA came out and made the statement that obesity is a disease. I think that will only continue, as Ted Kyle was talking about this afternoon, the treatment of obesity as a disease, and it will only help going forward. So please feel free to stop and ask questions. I'd rather have this more of a discussion than a lecture. So, as I said, why all the interest in obesity? It is the most, in my opinion, the most important disease and healthcare crisis facing the nation today. There's new treatment, both surgically and medically, that we'll talk about. And finally, the epidemic of obesity. And I have an asterisk there. I'm fortunate enough to be on the CDC task force for obesity. And I talk about the epidemic of obesity in central Pennsylvania. And one of the nutritional epidemiologists said, we really don't have an epidemic yet. It's just an accelerated outbreak. So I don't really know what the definitions are, but I think we have a big problem. If we look, this is NHANES data, you probably have seen this, but on the top line are the individuals that are overweight, and the gray boxes are individuals that are obese. And we can see up until 1980, we were quite stable. Individuals, about 45% of us were overweight, and about 14% of us were obese. However, over the last 20 years, there's been a significant increase in individuals that are both obese and overweight. And in 2010, 73% of us were overweight, and almost 40% of us are obese. So whether it's an epidemic or not, it's a big problem. So we're going to just briefly look at the factors causing that and then talk about treatment options that we have. I'm not going to talk specifically about pediatric obesity, but this says, remember when we had to fatten up the kids first from Hansel and Gretel. But really, that has been a big problem, and we know that prevention is better than treatment that we have. And we just heard from the CDC that there's several states that have had a decrease or a plateauing and slight decrease in individuals, children that were overweight and obese. So that's very, very encouraging. The other thing is this is not just in the United States. Michelangelo's The David returns after a 6-month tour in the United States as this. This is the best I have as jokes, so The World Health Organization recently just said that there's more people overweight and obese in this world now than underweight. That is a huge, huge problem, I think. So what's affected this weight over the last 25 years? I broke it up into 4 different buckets, if you will. Food availability and composition will take first. So really, there's definitely a genetic susceptibility or genetic predisposition, both environmentally and how we're born. And we'll talk about that briefly, because I think that really gives some inroads into treatment. Because no matter what we do, there may be factors physiologically and genetic that are preventing us from losing weight and may be influential in regaining weight after we lose weight. So we'll talk about that. But basically, there's a sedentary lifestyle with regards to energy expenditure and energy intake, and with regards to food consumption. So we're going to see this a couple times throughout. We're going to talk about the left-hand side initially. So everything we can take in has to be 3 things: protein, carbohydrate, and fat. Those are the only 3 macronutrients. Everything we put in our mouth has to be either a protein, carbohydrate, or fat. Also alcohol, and some individuals consume quite an abundance of calories. And remember, alcohol, if we have extra adiposity, is empty calories. It goes right to fat. And if we recall, protein is 4 calories per gram. Carbohydrate is also 4 calories per gram. But fat is 9 calories per gram. So it's double the amount of calories per gram. So that's why with regards to any type of diets, really, we try to decrease the fat content, because that's cutting the calories from fat in half. So that's an easy way to do that. If we look at alcohol, it's actually metabolized at 11 calories per gram. So it's empty calories, it goes right to fat. So just make sure that we take that into account with regards to our alcohol consumption. Now, I'll just say that there's been several studies that looked at which percentage of carbohydrates are best. And Gary Foster, who you're going to hear speak tomorrow, is a great lecturer, a great clinician and researcher. He did a nice study and he looked at the difference on carbohydrates, whether high carbohydrate, high fat, low fat, high protein, low protein. And for the large majority of individuals, it really didn't matter. It was really caloric restriction and adherence, meaning it didn't matter what type of macronutrient diet we're on, but if we reduced our calories and we stuck to it, we would all lose weight. So I think that's very, very important. Now, if we go to individually, there are some factors of how we carry our weight, and we'll talk about that may alter the percentage of carbohydrates versus fat versus protein that I think may benefit some individuals over others. And it's not specifically on our body mass index, but it's actually how we carry our weight. With regards to pediatric and adolescents, and this goes to adults too, the first thing that I like to try to do is to avoid all caloric beverages. So whether we know it or not, people can drink thousands of calories a week in regular sodas, fruit juices, and caloric beverages. So that's an easy thing. And if we look at pediatric and adolescent obesity, there's 2 things, or actually 3 things that have shown to fall out with regards to positive treatment or positive behavioral changes in pediatric and adolescent obesity. One is reduction or elimination of caloric beverages with the exception of low-fat or skim milk. Number 2 is eating as a family unit at least 3 times a week. And number 3 is limiting screen times to no more than 2 hours a day. So if we can do those 3 things, and they're big things for a lot of kids. I mean, even in our house, it's hard to sit down 3 nights a week as a family unit around the table. Everybody's busy, but I think that the more we do that, it's been shown that we reduce calories per meal by about 20 to 25% if we can eat at a family unit versus eating on the road or outside of the kitchen. So the big thing is caloric beverages. The other thing is food is cheap. I mean, we can get an abundance or unlimited amount of calories for under $5, a buffet. The other thing that we're not too good at, we don't do too well at it, is calories counting. We really have no idea how many calories are in things. And we're packaged people. We're not really serving people. So, people will eat this whole container and think they've only eaten 100 calories, but really there's 4 servings per serving. 4 servings per container at 100 calories per serving, so they're actually eating 400 calories, which a lot of times they think they're only eating 100 calories. Now, there's good news is there's a lot of, and I'm sure you've seen them, 100-calorie snack and 100-calorie portioned snack and meals. I think those are very good. They're more expensive, but I think they're very well portion controlled, and I think they're trying to get us back to what a real portion is, or a prudent portion versus the masses of a whole box and that type of thing. So if we want to lose a pound, if we remember that it takes 1 pound equals 3,500 calories. So we try to decrease 500 calories a day for a week is 3,500 calories. So that's a pound a week. I think that is the type of weight loss that at least we encourage in our center, because that's more of a modest weight loss of a pound a week or 4 pounds a month that's more sustainable over this rapid weight loss. And so in our pre-op patient population, we do encourage a 5 to 10% weight loss. The average BMI that they operate on is 52 with a lot of disease burden. About 40% are diabetic, another 30% have obstructive sleep apnea and NASH. So a modest weight loss helps that. So we try to have them decrease their calories by about 500 calories a day, which promotes about a pound a week or 4 pounds a month. So that's the food composition and availability. The other thing that I think is crucial, especially in post-operative patients, is exercise. And we've heard a lot about exercise, but exercise really is not that effective for weight loss. It's helpful, but we can still lose weight without exercise. But what's key is weight maintenance. And so the patients that, specifically post-op patients that are losing rapid weight loss, they're losing a lot of lean body mass. And it's our lean body mass that maintains our metabolism. So our metabolism is really geared by our muscle mass, which is our lean body mass. And it's about 70% of our metabolism is our lean body mass. There's another 20 to 25% of our activities of daily living, what we choose to do. And then there's a small amount called a thermogenesis of digestion. So when we eat a meal, we can feel our body temperature heating up. Our energy or our metabolism does increase about 2 to 3%. But by and large, our main driving engine, if you will, for our metabolism is our lean body mass. And I think that's crucial of how we try to maintain that, both with medical and surgical weight loss. So this is on the other side of this equation. So this is energy expenditure. As I said, our basal metabolic rate is really determined by our lean body mass. It affects a small amount by the thermal effect of food. But the big thing is energy expenditure. Is that blurry or is that me? Okay, good. I thought, whoa, I didn't even have anything to drink. So a lot of things that we do to make ourselves a lot easier throughout the day, but actually it decreases our energy expenditure. These are just energy-saving tips that we do. One little fact that I have is a remote control. To the remote control for our television, if our body mass index is 30 or more, we don't walk 1.2 miles per year just because of that remote control. And it averages about 2 pounds a year just using that. So these little things add up. And so if we can, walk further when we park in the parking lot, if we work on the 4th floor, take the stairs for 2 out of the 4 floors, all that thing increases our energy expenditure. And in a week's time, in a month's time, in a year's time, we can really make some headway on just these little gadgets that we do in our daily life to decrease energy expenditure. We need to try to turn that around to increase energy expenditure. I mean, it's hard. Not only do I use a remote control, I have my 8-year-old get me the remote control, and then I use it. So we don't want to set our patients up to fail. We really have to be realistic on what we ask to do, and we'll talk about exercise in just a minute. The other thing that affects weight, and I think is very important, whether it's pre- or post-operative or medical management or surgical patients, is depression. We know that as our body mass index increases, so does the rate of non-suicidal depression. And the average incidence of depression of the total population in the United States is about 11%. If we look at a cohort of body mass index of 40 or greater, it's about 23%. So I think it's very important. We use the Beck Depression Score. You can use really any score, but I think it's important to screen for depression because if we're depressed or dysthymic, we tend to self-medicate with food, specifically carbohydrates. Those are, the breads, pastas, rice, potatoes, corn, cereal, any type of simple sugars. Those increase serotonin. That's a neurotransmitter in our brain that gives us that calming, content feeling. The problem is it only lasts about 10 or 15 minutes, and then we go into that grazing type of mode. So by taking a serotonin reuptake inhibitor or medication or psychotherapy, it really doesn't matter, but either pharmacotherapy or psychotherapy, that SSRI or that medication keeps serotonin around longer, so we're not grazing to keep serotonin levels up. Very, very important, not only for the well-being of mood, but also a big thing is the appetite in that grazing type of mode. And a lot of times there's that high incidence of depression in the bariatric surgery patients. Then there's the honeymoon phase after surgery where everything is great. And then about 9 to 12 months down the road, you find out, the surgery didn't help your marriage. You're still miserable at work. You still are stressed. You still have to work 2 jobs. The kids are still... So it's not a miracle cure that we thought it was. So, and a lot of times we're not screened to see if we need any help with our mood, and we tend to self-medicate with food. So I think that that's very important. And anybody that comes in with post-operative weight regain, we always look at that along with quality of life, because that can go a long way in helping individuals get back on track. The other thing is metabolism, what affects weight. There's genetics, and there's 2 types of genetics. There's the single gene deletions, like Prader-Willi syndrome, the Cohen syndrome, and the red hair single gene deletion. Those are very, very rare. But they do have a high predilection for obesity. What has not been well described until recently, since these new GWAS types of studies, is everyday or exogenous obesity. So there's about 21 obesity genes that we know of right now. And what we found, at least in the post-op surgical patients, that we published a study looking at 7 different obesity genes. And as you recall, from your mother, you get an allele, and your father, you get an allele. So if we looked at 7 genes, that was a total of 14 alleles. So what we found is after surgery, if we have an allele burden, if you will, so if we genotyped you for these 7 genes, and you had a lot of alleles, you are at higher risk of not losing as much weight as we thought you should have, or gaining back weight. So that's important for 2 reasons. So if we do genotype you before, and we're born with these genes. These are not acquired or environmentally acquired genes. We're born with these genes. So if we know going into surgery that you have these allele burden, that we can follow you more aggressively or have you more accountable after surgery to try to make sure that you get on the right trajectory of weight loss and weight maintenance. But the other thing I think is helpful, knowing preoperatively, if you have very few of these alleles, we are pretty confident that you're going to lose weight and keep it off. So I think this is just the tip of the iceberg. There's a term called pharmacogenomics. So there are several medications that we know based on our genetic makeup work better than others. So we coined the term on this paper, surgicogenomics, based on our genetics, how well is a surgery going to work? And like I said, there's other types of studies being done with a larger number of genes to try to personalize that individual with the right procedure. The other option, if we know that they may have 14 alleles, then I would probably recommend more of an aggressive treatment, maybe a duodenal switch or more of a malabsorptive procedure than a band, sleeve, or a gastric bypass in someone that we know that's high risk for not losing weight and keeping it off. The other thing is the medications. These are not weight loss medications that we're going to talk about, but these are medications that actually can promote weight gain. We always want to take a good medical history to make sure that we're not prescribing anything, or your physicians are not prescribing anything that can promote weight gain. With regards to the anti-diabetic medications, hopefully post-operatively you're off a lot of them, but there are a couple of medications, the thioglytazones. Those are medications that can cause weight gain and increase your body water. The other one is insulin, as you know, it's an anabolic hormone. It can cause weight gain or retard weight loss. Antipsychotic medications can cause weight gain, but I usually don't touch anybody's antipsychotic medication if they're on it. Antidepressants. So there's been a lot of press about which antidepressants cause weight gain, which cause weight loss, and which are weight neutral. By and large, the class of the SSRIs, the serotonin reuptake inhibitor, the Prozac, the Paxils, the Zoloft, those are all weight neutral by and large. Paxil, however, can cause weight gain in about 20% of individuals. So it's a good medication, but it can cause weight gain in some individuals. The other ones that can cause weight gain are the tricyclics, the Elavil. They're often prescribed at night for sleep after bariatric surgery in a lot of patients. In the short term, it's no problem, but in long term, tricyclic antidepressants can cause weight gain. And the other one is Remeron. That also is an antidepressant that can cause weight gain and increase in appetite. Anti-epileptic medications, the one we're going to talk about is topiramate or Topamax. That actually causes weight loss, and what they showed when it was being treated for seizures and chronic pain, that these individuals lost weight. And so it was just FDA approved in combination with phentermine for weight loss, and we'll talk about that in just a minute. And also corticosteroids and antihistamines can promote weight gain. So it's important to know what medications we're taking and do they promote or weight loss or weight regain. Okay. It's not moving, James. Any questions? Yes, thank you. Go ahead.
I noticed at the start you mentioned that the definition is just less calories in and out, right? And that's how you lose weight.
What I said, yes.
Make sure I clarify that because that really simplified it.
Well, no, what I meant to say, if you look at all, remember, they wanted to know, there's several studies, but they all said which diet is best for us. Is it the Atkins diet? Is it the Mediterranean diet? Is it the Pritikin diet? Is it high fat, low fat? And what they showed, if you look at all those different diets, they all lost weight. And the common denominator was if you lowered your calories and kept on it, regardless of whether it was high fat, high carbohydrate, low carbohydrate, it all worked. I'm going to show you now on an individual basis that one may be better than the other based on our individual makeup.
My wife tried all of them and it worked for a month to 3 months, and then she stayed strictly on it, same exercise, same calories, and gained weight up to 60 pounds.
Yep. Well, that's the chronicity, and that's the set point, and when we can only lose so much, and our body does things to try to promote or try to prevent weight loss and promote weight regain. So there's a lot of factors going against us, and I'll talk about a couple of them. But that's not uncommon, actually, that we can hit a common point. And for medical management, I mean, that's really what we can do, a 5 to 10% weight loss. And that's good for controlling a lot of medical problems, but we all know surgical treatment is much better and more sustaining than what we can do on medical weight loss. The other thing that I think is important, and even with surgery, is weight loss is different than weight maintenance. And I think what you'll see in the next 5 to 10 years, that there's going to be medications that are FDA approved for weight loss, and also what are going to be used for weight maintenance. Because some medications, because of our insulin resistance, our leptin resistance, are going to be more effective at a lower weight than they were at helping with weight loss from the get-go. So I think that is very beneficial, but we just need to weed out which medications are better for weight loss and which are better for weight maintenance. So with the definition of obesity you're all familiar with, it's the body mass index. It really takes into account our weight, and it correlates with morbidity and mortality. So as our body mass index goes up, so does the rate of developing comorbid medical problems and also morbidity and mortality. So we all know that our body mass index, a normal BMI is between 20 and 25. 25 to 30 is overweight. Class 1 obesity is 30 to 35. Class 2 is 35 to 40. And extreme obesity is 40 and greater. So as I said, the average BMI that we operate on at our institution is about 51. I think that the problem is this pointer and so can I go back? Thanks. So we don't have to do medically or surgically. The goal is not to get someone from a body mass index of 52 down to a body mass index of 22, a normal BMI. But even a modest weight loss has significant benefit on bringing you down on this scale and helping the comorbid medical problems. As I said, clearly, surgical treatment is more effective for weight loss and also the weight maintenance of it. But even a modest weight loss can have significant benefit. Next slide. Thanks. This is all the comorbid medical problems, as you're all aware of. There's only one medical benefit of being overweight. Does anybody know what that is? The decreased risk of osteoporosis. Very good. That's because of the bone density. But when you go through bariatric surgery or aggressive weight loss, that takes that away too. But the good news is it improves all of these comorbid medical problems. And really, as an internal medicine physician, that's the real reason for recommending bariatric surgery. The weight loss is actually secondary to the profound medical benefits of resolving a lot of these comorbid medical problems. Next. So this is where I wanted to get at with regards to individualizing the meal plan. So on the left-hand side, that has more of a subcutaneous adipose tissue. So this is more subcutaneous adipose tissue of the buttocks and hips. This is more genetically predisposed. It's more white adipose tissue. Usually the man on the right has more visceral fat, more apple shape. That's much more metabolically active. This individual has much higher rate of diabetes, sleep apnea, fatty liver disease, cardiovascular disease, hypertension. On the left, that's actually cardioprotective. Those individuals usually have a higher HDL cholesterol, a lower LDL cholesterol, lower incidence of diabetes, sleep apnea, and fatty liver disease. Unfortunately, over the last 20 years with the increase or the epidemic of obesity, so it used to be that women had the pear and men had the apple, and that those comorbid medical problems in women were not predominant until they went through menopause and lost that estrogen effect. But unfortunately, over the last 20 years, women are taking on more of this visceral fat distribution that's much more metabolically active. So women are having diabetes, sleep apnea, fatty liver disease, cardiovascular disease that was initially really a male-predominant disease until after menopause. So how we carry our weight, independent of body mass index, is very important. And so we'll see that in women, a waist circumference around our umbilicus greater than 35, and in men greater than 40 connotates that upper body weight distribution. In those individuals may benefit from more of a carbohydrate modified meal plan, so lean meats, fruits, and vegetables, more of a Mediterranean type weight program to decrease the insulin production versus a low-fat diet. A low-fat diet, by definition, increases the carbohydrates. That has been shown to help for cardiovascular disease, but it's probably not the best for this individual that has the weight through their midsection. If they're just visceral or subcutaneous fat of the buttocks of hips, maybe just going on a low-fat diet would be helpful. So how we carry our weight with regards to this metabolically active or the apple versus the pear, I think is very, very important. And I would bet you that initially you could lose weight on any diet, but if you have this type of weight distribution, decreasing your breads, pastas, rice, potatoes, corn, and cereal, still making it 55% carbohydrates, but try to increase the fruits, vegetables, legumes, and salads, which are all carbohydrates. You'll have a much easier time at losing weight with this visceral type of adipose tissue. Also, it will be much easier in controlling blood sugar. Next slide. So how do we treat obesity? The components of you can have the best surgeon, the best procedure, the best pharmacotherapy, the best lotion, potion, doesn't matter what it is, but the cornerstone has to be diet, exercise, and behavior modification. You can just put the next 4 slides. So diet, exercise, behavior modification. So medications and back one. So we're going to talk about medications and surgery, but clearly, even the best surgeon, and what I usually say is, 9 months after surgery, everybody's a medical management patient. So we need that continued accountability for diet, exercise, and behavior modification. Next slide. So just some poignant things, I think, with regards to a treatment plan. As I talked about, we really have no idea how many calories we take in. So keeping track of our calories is very important. Even the best dietitians underestimate our calories by about 10 to 15%. So we don't have to keep calories counts or keep food logs forever, but we really need to get a handle on how many calories we take in a day. And it's very easy now. There's great types of apps and electronic gadgets that are handheld real-time that really help us in our budget of how many calories we're taking in. Also in our energy expenditure, it'll tell us how many calories we've burned so far. So we've come a long way in that department, and it is very fascinating to see the development of all those different tools to help us become accountable. Getting weighed once a week is very important. Once we talk ourselves out of getting weighed, it's really hard to get back on track. So getting weighed outside of your home once a week, the best day is Friday to get weighed, and then the worst day is Monday, because we sort of get weighed on Friday, have a nice weekend, and then jump back in on Monday. So Monday's the best. As we talked about, and what we'll see is the biggest thing for weight maintenance, not so much for weight loss, is exercise. And it's because as we lose weight, our lean body mass decreases. So it's been very hard, at least over the years, to get our patients to exercise. So we went through this occurrence type of exercise, just a pedometer type. So they can do 5 minutes, 6 times a day, 10 minutes, 3 times a day, doesn't really matter. 30 minutes over a 24-hour period, or 8 to 10,000 steps on a pedometer equals that 30 minutes over a 24-hour period. That really increased the adherence to exercise, and it's something objective that they can see how many steps they get in on a daily basis. Water intake is very important. As we lose weight, our body conserves fat stores, so the only way we can maintain our rate of lipolysis or fat breakdown is by drinking 64 ounces of water a day. It's very, very important. So 2 things if we're having problems with weight maintenance or if we've plateaued, really the water intake is key for maintaining the lipolysis, which is just fat breakdown through our liver, and also exercise because of the lean body mass that we talked about. The other thing is drinking something hot. Doesn't really matter what it is, coffee, tea, bouillon, hot water, but that stimulates our satiety center in our brain. Very, very effective in decreasing appetite. Our satiety center in our brain will still tell us that we're finished eating or satiated, but it takes about 20 to 25 minutes. We can eat 2 and 3 helpings and be out the door before our brain even tells us that we're done. So drinking something hot, preferably 15 minutes prior to your meal or concomitantly, will decrease calories by about 10 to 15% per meal or snack. That's really, really a huge benefit. Pharmacotherapy if weight loss plateaus, and then bariatric surgery. Next slide. So this is just the importance of exercise. So you can see the top line is 1,200 calories, 1,500 calories, no exercise. The line in the middle is 1,500 calories, no exercise. So that shows you that 1,500 calories, no exercise at the top, 1,200 calories in the middle. So if we reduce our calories, we're going to lose more weight. The purple line is 1,200 calories with exercise, and you can see the people that exercise maintain weight nicely. If you don't exercise, you gain your weight back very easily. That's with medical or surgical. So that is really, really key. Not so much for weight loss, but for weight maintenance. Next slide. So weight loss pharmacotherapy. Next slide. Oh, this just says, this announcement is for the women in the red dress in aisle 12 or just purchased the diet pills from the pharmacy, put back the bag of M&Ms. That these are not standalone medications. Who remembers fen-phen? Does anyone remember fen-phen? So fen-phen was phentermine and fenfluramine. They were done, that was popular in the 80s and 90s, and it was very, very effective for appetite suppression. If you talk to people that were on it, it was the first time that they actually really felt satiated. The problem was fenfluramine and dexfenfluramine had problems with valvular heart disease and primary pulmonary hypertension, and they were taken off the market. But there's newer medications that are safe and effective that we're going to talk about. Next slide. So 200 medications to treat hypertension, 10 classes of medications, and 100 medication choices for diabetes, and just a few choices for obesity, despite the epidemic of obesity, of the disease of obesity. Next slide. The FDA has not approved a new prescription medication, weight loss medication, in how many years? Anybody know? When was the last one that's gone? Close. Not so bad, but pretty bad. Next slide. 13 years. So you're very close. But that's pretty, I think, unbelievable, actually. But the good news is we have 2 out, one hopefully in the next couple years, and several more in the pipeline. Next slide. So anti-obesity medications, no non-drug treatment intervention, as we talked about diet, exercise, and behavior modification before considering pharmacotherapy. Patients, they're FDA approved with a BMI of greater than 30 or a body mass index of 27 with a comorbid medical problem such as diabetes, sleep apnea, fatty liver. Next slide. So the problem was the effectiveness of the 2 medications. Phentermine, a 4 to 5% average weight loss in 3 months. So that's only approved for short-term use, which is 90 days. In most states, you can use it longer. You just need to document that there's no cardiopulmonary problems. The other one is Xenical. That's a lipase inhibitor. It blocks 30% of all ingested fat. A lot of people think it breaks down fat that we already have stored. It really doesn't at all. It blocks fat that we consume from being absorbed. And that's the treatment effect, if you will, if you eat too much fat and take the orlistat. But on average, it's about 3 to 4% weight loss after 1 year. It is now over the counter at 60 milligram dose in the name of Ally. Next slide. So what I always like to do before I treat anybody with anti-obesity drugs, I look at the physiologic problem, and I always try to screen for insulin resistance. Insulin resistance is very, very high. All that means is it takes more insulin. As we get heavier, it takes more insulin produced by our pancreas to keep our blood sugar normal. We're not diabetic, it's that pre-diabetes, if you will. But it still produces weight gain or retards weight loss because we're producing more insulin to keep our blood sugar normal. So a simple test is a fasting glucose and a fasting insulin. And that just a simple ratio of glucose divided by insulin. If that ratio is less than 5, by definition, we have insulin resistance. And I would consider the off-label use of a medication called metformin or glucophage. It's just an insulin sensitizer that affects the liver, and it helps with weight loss. That would get more bang for your buck if you're insulin resistant than really any of the weight loss medications. If that is okay, then I would move on, or after you use the medication, if it's indicated, then I would move on to use one of the anti-obesity medications. Next slide. So these are the new medications, Belviq by Arena Pharmaceuticals, or Lacarcerin. It was initially denied by the FDA board, but it was approved in 2012. And it came on the market this year. It is on the market today. We'll talk about it in just a minute. Qsymia is a combination of phentermine and topiramate. It also was approved at the same time, and it is also on the market today. And Contrave, that's a combination of bupropion and naltrexone. It actually was up at the same time, but it was denied because of an elevation in blood pressure, slight elevation in blood pressure. Remember, with weight loss, our blood pressure should decrease. But in that trial, one of the trials, there was actually a slight uptake, so they wanted them to follow up and do follow-up cardiovascular trials, which is on its way now, and it should be FDA brought up again in 2014. Next slide. So this is the mechanism of action. The lacarcerin is a serotonin reuptake inhibitor, just like the fenfluramine was, but the good news is the fenfluramine was a 5-HT2B receptor. This is a 5-HT2C receptor, which has no effect on the heart and primary pulmonary hypertension, which is good. The other one is the combination of phentermine and topiramate that we talked about. And topiramate was the medication that was used for chronic migraines, chronic pain, and seizures. Next slide. This goes through the efficacy. So phentermine after 1 year is about a 4 kilogram weight loss. That topiramate and phentermine combination. And the topiramate that's used in this preparation is not what we use if we were prescribed for your patients or if you're on today. This is an extended release topiramate that's unique to this compound. You can see about a 12 kilogram weight loss. The bupropion and naltrexone, 6.2% kilogram weight loss. And then the lacarcerin, about a 5 kilogram weight loss. So as I said, as any type of weight loss, even a modest weight loss, can have significant impact on addressing the comorbid medical problems. It's not as good, the efficacy on any of these medications are nowhere near the efficacy of bariatric surgery, but there's plenty of room for patients to be on anti-obesity medications or weight loss medications even before or after bariatric surgery. We use a lot of these medications in postoperative weight gain or plateauing after bariatric surgery. So picking the right patient for the right medication. So if someone was on an antidepressant medication, say Prozac, then I probably would not look at Belviq because of the possibility of serotonin syndrome. If someone had problems with hypertension or cardiovascular disease, then I would probably look for lacarcerin rather than the topiramate phentermine. So it really depends on patient selection of what medication I would choose first. And the other thing is with regards to cost. Coverage is growing in the United States, but it's still very patchy, and the cost per month of these can be pretty high. So you want to make sure that you choose the best medication for the best patient because you want them to be the most efficacious. So, but they'll get more bang for their buck if you use it in combination of diet, exercise, and behavior modification. Very, very important. Next slide. Bariatric surgery. So this is the most sustainable long-term weight loss. It's not a cosmetic procedure. It cures, improves obesity-related comorbidities. And actually, the weight loss is secondary to the profound medical benefits. Next slide. So you may all know this, but the three most common are gastric bypass, the adjustable gastric band, and the sleeve gastrectomy. These two are restrictive procedures. So this just, the gastric sleeve just does exactly what it says. It makes a sleeve, if you will. It takes out this part of the stomach, and in that part of the stomach is the ghrelin-secreting cells. Those are the hunger hormones. So by taking those out, excluding those, there's a physiologic decrease in appetite and also gives you the restriction. This procedure is now done as a primary procedure, but not too long ago, maybe 5 years ago, this was done as a secondary stage to a duodenal switch. So they would just do this procedure, have the patient lose weight, make them less high risk, and then come in and do the second part of the procedure. What they found is individuals would lose weight just with this alone, so now it's done just as a primary procedure. The gastric band is a band around the top part of the stomach and a port that comes underneath the skin. You instill saline into this port, and it cinches up that band, causing a restrictive portion of the gastric pouch. The most common continues to be today is the gastric bypass. That's a combination of a restrictive and malabsorption procedure. They bypass the majority of the stomach and the first part of the small intestine. So food comes down the esophagus, into the 30 ml pouch, and then down into the second part of the small intestine. So that's a restrictive and malabsorptive component. The gold standard still remains the gastric bypass. When we talk about the efficacy, there's a lot of people that usually quote 70% excess body weight for the gastric bypass, 40 to 50% excess body weight for the band, and 40 to 50% excess body weight for the bypass. I will tell you that I think that's very generous for the gastric bypass. And there's a free app that we developed at Geisinger. I don't know, has anybody ever heard of Get to Goal? Oh, good. So it is an app that's free through Apple, and you can download it, and it just will tell you, based on your height, age, and weight, preoperatively, what you can predict to lose at 1 year, 2 years, and 3 years out. And if you've already had surgery, all you need to do is put in your weight at surgery, and it'll tell you where you are on the 90th percentile, 50th percentile, and 10th percentile. And it was validated not only in our cohort, but against 100,000 patients at the BOLD database. So it just gives you a better idea that people have very unrealistic expectations, I think, and that will give you a better understanding of where you are more realistically. Because I think a lot of patients are doing much, much better than they think they are supposed to do. Next slide. So this is just a meta-analysis of about 22,000 surgeries, surgical patients. Next slide. And they looked at risk, and they looked at comorbid medical problem resolution, and they looked at weight loss. Next slide. So excess weight loss, so about gastric banding was about 50% excess weight loss, 60% for the gastric bypass, and the duodenal switch was about 70% of excess body weight. The comorbid medical problem resolution, that's what I think is most important. Next slide. So diabetes, there was a 76% remission in diabetes. Next slide. Hyperlipidemia, 70%. Hypertension, 60%. And obstructive sleep apnea, 85%. So there again, the weight loss is secondary to the profound medical benefit. I will just say, and I feel like I'm self-absorbent, but we just got a paper published in Lancet to show preoperative equation for predicting resolution of diabetes after gastric bypass. So there again, we try to personalize what to expect after surgery with regards to weight loss and comorbid medical problem resolution, and diabetes obviously is the biggest. So it's just a simple equation. You can put in some preoperative factors and tell you what percentage of a chance you have at resolving your diabetes after gastric bypass. Next slide. The good news is the safety profile has significantly improved. Bariatric surgery is on the left. The mortality rate is 0.13. Lap chole is 0.32. I can't even read that. I'm right here. 5, thanks. 0.52. Hip replacement is that. Thank you. And CABG is higher. So, but the caveat to this is when performed in a center of excellence, and I think that is very important. Next slide. The other thing is, the last slide is that doing nothing is not without risk too. So this is a nice looking at people that underwent bariatric surgery. There was a 0.6% mortality versus control did nothing or no surgery had a 6.1% mortality. So it's nowhere near, it's not for everybody, but I think you have to weigh the risk-benefit of controlling the comorbid medical problems versus the weight loss. Thank you very much. I'll be happy to answer any questions that you may have. Combination medication? The only combination medications are the ones that are FDA approved. So the phentermine and topiramate, and the naltrexone and bupropion. There are some people that I have no data on it, but say using phentermine and lacarcerin or other combination of GLP-1 and diabetic medications. They are being done, but there's really no studies being done that I can give you any data on.
You also mentioned that 70% reduction in bariatric U&Y, and with the behavior modification, diet, exercise, and pharmacotherapy, what is the, you have alluded to this fact, what is the average weight loss, sustainable weight loss of patients as opposed to surgery?
Oh, as opposed to surgery? It's about, if you look at, so you're looking at medical management. Let me just make sure this is medical management with diet, exercise, behavior modification, and pharmacotherapy. It's about an 8 to 10%, not excess body weight, but real weight loss. So medical management usually reports in just percentage of weight loss, surgical percentage, and they're changing that to make it more unified, is percent excess body weight loss, if that makes sense. So the problem is not losing the weight with medical management, it's keeping it off. And that's why I think that there are medications that are going to be better for weight loss, and then there are going to be medications that are better for weight maintenance. Thank you very much.